Okay, good morning, and the good thing is this is a very rare occurrence. It's so rare that there's literally nothing published about it. And fortunately, I've only had to deal with it once or twice. So this is going to be more of what I do when I encounter this. So what I wanted to start with is a patient of mine from a little over 3 years ago. And this was a 68-year-old female who was referred to me for severe MR and persistent AFib. The echo, which was obtained 2 months prior to seeing me, demonstrated severe MR with P2 prolapse, an ejection fraction of about 55%, and reported normal LV size and normal RV function. And she just began to have class 2 symptoms. Her other medical history was ulcerative colitis. So I scheduled her for surgery approximately 2 months after I'd seen her. That was for a variety of reasons, primarily because of my clinical volume. Her cath demonstrated non-obstructive coronary disease. It was a right dominant system, and she had some pulmonary hypertension, as you can see there. So we get into the OR, and she's in rapid AFib. At that point, her heart rate was in the 110s to 120s, and this is the echo that we see. And so immediately I'm alarmed. You can see that this is not an ejection fraction of 55%. The LV is dilated, and there's also significant RV dysfunction. So with that in my mind, I'm already planning on how I'm going to come off pump with this lady. So what we did was ascending aortic and bicable venous cannulation, antegrade and retrograde cardioplegia, and we redosed at 20 minutes intervals in topical hypothermia, as well as moderate hypothermia cooling to 33, 34 degrees. The repair consisted of a combination of resection and neocord replacement and an annuloplasty with a 40 millimeter partial flexible band and a biatrial maze with cryo. Cross clamp time was 73 minutes, and we loaded her with milrinone and began an epi infusion. And this is what she looked like when we started to fill. So you can see severely reduced biventricular function. You can see there's a little bit of anterior wall motion, but the rest of it is LV is kind of along for the ride. So in my mind, you're thinking, well, why did this happen? And now what do I do? So why did this happen? Well, I think you have to go through a series of thoughts and think of them very carefully to help guide your next step. So ischemia. Was there a possibility of coronary injury, most commonly circumflex? I think also what you have to be aware of, especially when you're doing a maze and on the right side, is there has been reports of right coronary artery injury as you take the probe and go across the tricuspid annulus. Is it inadequate preservation? Always a possibility. I thought we protected this heart pretty well with redosing at regular intervals, and we used appropriate hypothermia. Is it an inflammatory response in vasoplegia syndrome? Possibly. And is it afterload mismatch, which we see frequently in severe MR after repair? So are there any predictors of LV dysfunction after mitral valve surgery? I just chose 2 publications here, one from the Mayo Clinic and one from Mount Sinai. These aren't necessarily ones that demonstrate severe LV dysfunction with the inability to wean from pump, but they have defined predictors of decreased function after repair. Interestingly, the Mayo Clinic paper here was with patients supposedly with normal LV function. EF is 60%. What they found that if you had a systolic dimension of 36 millimeters or greater or pulmonary hypertension, you had a 4 to 6.5 fold increase of LV dysfunction. It occurred in about 20% of their patients. And interestingly, only 30% of the patients that had this dysfunction recovered back to their baseline. Also, your degree of congestive heart failure. The Mount Sinai group also demonstrated the presence of atrial fibrillation in accordance with pulmonary hypertension, also predicted decreased function. So these are things I think we have to be aware of and things that we can definitely get quite easily before surgery. It also is common in the TEER group. And I don't know how many of us know that, but I thought this would be good to show that this is a study where 26% of the patients had significant decrease in their LV function after a clip placement. And their findings that predicted it were systolic and diastolic dimension, RV dysfunction, and pulmonary hypertension. All right, so let's go back to this case. So I'm faced with this now, and the question is, what do I do next? Well, I start praying the rosary like I always do, and then in addition to that, I return to full cardiopulmonary bypass, and then I try to optimize inotropes and vasoconstrictors, primarily wanting to improve forward flow and reduce afterload. Additionally, inhaled pulmonary vasodilator, so we started nitric oxide. Also, agents to mediate the potential of inflammation, steroids. I also remember using methylene blue and vitamin B12. At that point, also, given the significant degree of biventricular dysfunction, I think it's reasonable to put an intra-aortic balloon pump. I think in these situations in general, you shouldn't feel embarrassed to do things, right? So you made a comment before, and as you go down this, you can't think about, oh, what are they going to think? What's my partner going to think? That needs to go out the door. So after we did this, we tried to come off pump again, and we actually were able to separate from cardiopulmonary bypass, but we were basically skimming the treetops. And so the question is, do I go to the ICU with an open chest, on max pressors with very little room for a margin of error, and I don't have an anesthesiologist giving him boluses, or do you go take it to the next level, which is exactly what we did. And the other comment is if you are going to go to the ICU in that scenario, you know in a couple hours you're going to be back in the OR in a much worse state, because now you're going to be in really bad multi-organ dysfunction. So I then elected to transition to VA ECMO, central cannulation, and then I went to the cath lab because I wanted to make sure that I didn't have a coronary injury. And again, don't be embarrassed, right? I mean, if anything, I think the cardiologist or your colleagues are going to say, you're a very thorough and thoughtful surgeon. I mean, I think that's the important message here. So we did go to the cath lab. There was no coronary. The coronaries were fine. And so then we went to the ICU, and over the course of the next 6 days, this patient progressively improved, was generating pulsatility on weaning trials of ECMO. And then this is the post-op day 6. We return back to the OR, and this is what we see. So much improved biventricular function, and we were able to separate from ECMO. And then this is just, I follow my mitral patients for life, and so I see them once a year, and so this was just a couple months ago. And so now you can see virtually return of function, low gradient, and this lady is doing well. So I will say, like I said, it's very rare, but it can happen. I looked at our experience at Michigan, and we're actually writing this up, but over a little over a 20-year period, it happens about 0.02% of the time. Although if it happens, I mean, I showed you a nice heroic save, but using ECMO, for example, as a rescue, mortality is high. So in our series, it was roughly 50% in hospital mortality. I think the key is awareness, both pre-op, and this brings up another question as I reviewed this case, is there was a 4-month lag between the first echo and her getting to the OR. So one question is, if the patient's going to, you sit in clinic and you see this patient, well, geez, she barely has class 2 symptoms, normal ejection fraction, I have a long waiting list, so I can probably push her out. Well, when is the time period to get another echo? And I don't think we have the answer to that, right? Because clearly, the findings we saw in the OR, yes, she was in rapid AFib, and yes, it's under anesthetic, but that was a significant change from her pre-op echo. In patients that I see with a fair amount of dysfunction and have some of the criteria that I showed before, I have a low threshold for pre-admitting them, starting them on inotropes, getting a right heart cath, sometimes even putting a swan in them, and then prepping them for surgery. So I think that's something that we need to think about too to decrease this. And then again, in the OR, I think you have to be aware both what you see in the echo, and then you start you start thinking, you have to be prepared. It's not time to panic and throw everything at them all at once. I think you have to have a stepwise approach. You have to have an algorithm. I think it's also important not to waste time. I think you have to be efficient. So we took our time in, to some extent, in giving a shot at reperfusion, maximizing medical therapy and a balloon pump, and then it's like, all right, this clearly doesn't seem like it's working to the level that I want it to, so let's quickly just move to ECMO and live to fight another day. Thank you.
Thanks, Matt. We heard the talk earlier from D'Alessandro about right ventricular failure, and this is kind of more a biventricular failure. This kind of patient doesn't usually show up in mitral valve repair, I agree, but it does show up in aortic valve replacement for aortic regurgitation, coronary bypass grafting, and it's all the same principles. I think the awareness and acting fast is a good idea. I personally I might have put an intra-aortic balloon pump in before I even went on pump on this patient, but that's kind of an unusual thing to do.
Yep. The other thing I didn't mention here, just as a comment, is it seems like isolated percutaneous left-sided support is gaining popularity. This patient clearly wouldn't have benefited from that because she had biventricular support, but I know more people are using, there's some reports of using Impella pre and post, so I think that's something also that can be part of the armamentarium.
Yeah, definitely. I've got my teammates are putting an Impella 5.5 in my cabbage for tomorrow, today.
Yeah, so exactly. So we're seeing that.
Yeah, the preoperative optimization, maybe even a week at times, is a really good thing if you know the LV is terrible and you have right heart data that shows you that you have significant pulmonary hypertension.
Yep.
Putting them on, what we call inotropically directed diuresis, right, or something along those lines. Trying to get them dried out a bit and get their PA pressures down, and like Mark said, a balloon pump before you even go on, and then maybe even a week in advance, whatever it may be. But optimizing them is super helpful.
Yeah, and I think I actually admit these people to me pre-op because it has taken me a long time to convince cardiologists how to optimize these patients. A lot of times they'll look at them and say, oh no, they're euvolemic, they don't need any more diuresis, and that's wrong. I mean, I just was on the phone the other day with a nephrologist on a post-op patient that I had horrible MAC and aortic stenosis, so I did a double valve, a dialysis patient, and he didn't want to dialyze her afterwards. She went into a temporary third-degree heart block, and I was like, you got to take volume off, dude. Please, please. It's like, well, she looks good, she's on room. I was like, take it off. So these patients I manage because I think I have a better idea of how to optimize them pre-op. Yes, I have no problems. My team doesn't like it. The nurse practitioners and residents are like, why do we admit this patient should go to cardiology? But I have no qualms doing it.
Yeah, that patient caught you off guard because there was a change in the findings after that.
Correct.
4 months.
Yeah, this was different, and that brings up the question, like, when do you get another echo if you're going to have a significant wait period to get them into the OR?
Dr. Anyanu wrote a paper, I don't know, half a dozen years ago on using nicerotide preoperatively. That drug disappeared. I don't know what happened to it, but they now use Milrinone at Mount Sinai for those preoperative 3 or 4 days.
So do I.
Question?
Khalid Rashid from Islamabad, Pakistan. I think you partly just answered the question, and that is that even if an echo has been done 3 months or 4 months before, all our patients have a routine repeat echo done when they are admitted for surgery. So you could have been sort of better prepared if that echo was repeated at the time of admission. The second thing is in developing countries like my center does not have an ECMO capability. I mean, I'm embarrassed
good point.
to tell you. And do you think that just to balloon, you did all the right things, but just to balloon and an open chest would probably would have salvaged such a patient in centers which do not have ECMO?
So great questions. This lady was a same-day admit, so she presented to pre-op. So at that point, but like I said, I think this particular case has had me change my practice a little bit, that usually at the H&P, if it's been a long time before they've had an echo, I'll get a surface echo to assess it. You bring up a good point about if you don't have the resources. And I think the first step is if you don't have the resources, don't be ashamed to call a center that does. And we get calls from hospitals throughout the state that sometimes can't wean from pump, post-cardiotomy. And so I think that's the first thing. I do not think in this patient an open chest and a balloon pump would have resulted in the result that we had, right? Because we were already had very little margin to escalate at that point when I did come off pump. And lactates were still slowly increasing. So that tells me that I don't have that luxury in the ICU. And all I'm going to do is the patient's going to get sicker.
That's a
Time for
difficult,
one- oh,
yeah,
I'm sorry.
that is a difficult situation, though, when your resources are limited, but you have to deal with your resources.
Yeah.
In that case, yeah, this kind of patient probably you want to not tackle if you don't have some sort of support system. Last question.
One more question, please.
Augusto Donofrio, University of Padua, Italy. I really enjoyed your talk, and in particular, I'm really enjoying the discussion. I would like to go back to Impella. I agree that there are no indications for alone LV support, but what about the unloading of left ventricle in combination with ECMO? I think that this patient would really benefit from an LV unloading, and Impella, in my opinion, would have been a very good option in this case, because ECMO increases after the work of the left ventricle, so unloading would be important.
Yeah, at the time we didn't have the Impella 5, so maybe today would have been a little bit different. Again, I think the issue here was the RV dysfunction. So you have to keep that into consideration too. If you have severe biventricular dysfunction, I do think you need more aggressive support. I think isolated, or if you have an RV that you think can handle it, yes, I think unloading the LV with something like an isolated left-sided support is appropriate. But just Impella isn't benign either, right? I mean, it's not a benign device. It's not like, oh, it's so much better than ECMO, right? There's thrombosis. There's a whole bunch of other things that you need to be aware of. It's not the panacea of all.
Yeah, if you read the New York Times, you know how dangerous it can be.
Yes.
But one last thing.
I don't read that paper, but
We talked about the LV vent in Dr. D'Alessandro's case. We could also have vented the LV with a CP Impella, and we've done that a handful of times. Great session.
Thank you, everybody. See you soon.